The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Good evening, and we're live here tonight on Your Health, Your Choice. This evening, as usual, we have with us diabetologist Dr. Claude Khan, and we're going to be discussing a dynamic duo, or what we'll call the two terrorists of the medical world, hypertension in conjunction with diabetes. Now, we've been doing this program for about 10 years, and I know we've touched on this topic before, but we've never really looked at the way that they combine.
Yeah, I think we have talked about it separately, but unfortunately, the combination of these two, so the main emphasis of tonight's program is to demonstrate that people with diabetes and hypertension have much poor outcomes in terms of complications of diabetes. And I mean, I'll just bring up slide 3, which is a bit maybe overdone. Slide 3. I don't know if we're ready. We were rushing a little bit tonight, but yes, the two terrorists. So that's a little bit, maybe people will remember that.
It's quite a hyperbolic expression.
Yes, hyperbolic.
Very exaggerated.
Yes.
Or is it?
So diabetes and associated hypertension. So why are we saying that it's the two terrorists? Because very often diabetes can be present for many years, and we know that terrorists can often be in hidden cells, as it were, on covert operations. But I believe even more so, hypertension is even more deceptive because many people are walking around with hypertension and they are absolutely not aware of it. I think, you know, we're becoming more aware of diabetes, and people are, you know, very often will go and check their blood sugars. Blood pressure, yes, but it is often a hidden problem. And the combination of diabetes and hypertension is a fact of everyday clinical practice.
Right, so it's a common problem.
It's a common problem, yes.
I know you have, it's at slide 5 that demonstrates how common it is.
So these are some important figures to talk about and to think about. How common is this combination? Well, hypertension is twice as common in diabetes as in the general public. So it's twice as common in diabetes. New onset diabetics, DM is diabetes mellitus, is 2.5 times.
Just clarify that DM and the rest of the slides, DM will refer to diabetes mellitus, and then HTN will refer to hypertension.
Yes.
Yeah.
So new onset diabetes is 2.5 times present in hypertensive patients. So patients who are patients who have diabetes are much more likely to have hypertension, and people with hypertension are much more likely to have diabetes. But importantly, the third one, 20 to 40% of people with impaired glucose tolerance, so that's even before people get diabetes, may have hypertension. 40 to 50% of type 2 diabetics have hypertension, and that fifth statement and the last one, only a quarter of hypertensive patients in diabetes is controlled. And we could probably talk about why that is. And diabetes plus hypertension, and this is the big take-home message, diabetes and hypertension increases by 3-fold the cardiovascular risk. And we can just come off that and talk about...
So one is perpetuating the other?
Well, yes, it seems to be a vicious cycle, and I know later on in the program people can call in, and we'll give you the numbers later on, and you can also WhatsApp your messages. The numbers will, in fact, you can even start WhatsApping your messages in now, and the number will come up in a few minutes. But yes, diabetes and hypertension seem to perpetuate each other, and there are various reasons for that. But, you know, the figure that really came home to me, the last 3 statements, 40 to 50% of type 2 diabetics have hypertension. Only a quarter of hypertensives in diabetics are controlled, and we can talk about what we really mean by control. And the last statement was diabetes and hypertension increases cardiovascular risk. Now, remember, when we talk about cardiovascular risk, we're not just talking about heart attacks. Cardiovascular is cardiovascular. It means strokes, cerebrovascular events, peripheral vascular disease. So it's the three things in combination puts you at higher risk. The diabetes and hypertension raises the risk of these problems.
So these are the causes then,
Yes.
on slide 6, the causes of...
So, yeah.
It's Joshua.
Yes. So what causes, so we have to slow down here a little bit.
I'm just aware that we have so many things to cover.
But I want to, if we could get these, this slide in addition to the last slide, we may not be able to cover everything. But so there's something called metabolic syndrome, and I have to explain what metabolic syndrome is.
Yeah.
IR means insulin resistance, endothelial dysfunction, and increased blood sugar. So that's those three things kind of summarize what metabolic syndrome is, and hypertension occurs because of that. There's something called a RAS activity, the renin-angiotensin-aldosterone system. That's a big medical term, but it's a enzyme pathway that if it's overactive, your blood pressure goes up. Hypertension due to nephropathy. So if you have kidney disease in diabetes, blood pressure goes up. Renal scarring. So I'm going to come back to that. Endocrine causes.
Yeah.
And sometimes some drugs can cause diabetes and hypertension. But I just wanted to go back to that first, the WhatsApp number was up.
Yes.
I think we forgot to take the number to repeat it. So the WhatsApp number is 360-0105. 360-0105. So you can start...
Yeah, we're live, so you can start sending in your questions, anything to do with hypertension and diabetes. Any questions you have, we will be happy to deal with it. Dr. Khan will, anyway.
Right. So metabolic syndrome, we talked about that.
Yes.
So in metabolic syndrome, you have what is called insulin resistance. So the body is producing insulin, but you're not able to respond to the insulin. And because of insulin resistance, there's a link to high blood pressure. Endothelial dysfunction. Now, this is an important concept. The lining of the blood vessels is called endothelium. And in diabetes and hypertension, the endothelium is really supposed to protect the blood vessels. It is supposed to prevent clotting, thrombosis, prevent vascular inflammation. But in diabetes and hypertension, that whole mechanism is disrupted. So you have thrombosis occurring easier. You have the blood vessels not being able to dilate. So you have constriction of the blood vessels. So the whole vascular tree is affected.
Okay, so that's these are the causes.
And well, one of the things I wanted to emphasize is renal scarring. And what we mean by that is that in diabetics, you can have silent UTIs, silent urinary tract infections. And as a result of that, you have damage to the kidneys. And the kidney is actually a very important organ in controlling blood pressure, and especially in end-stage renal failure. So high blood pressure can damage the kidneys, but as the kidneys become damaged, that sends up the blood pressure as well.
So again, everything is contingent on the other.
Right, yes.
I think that's a really good slide, slide 7, which shows how one perpetuates the other.
Yes.
So
it's, it's a vicious cycle, diabetes and hypertension going together. A question might be coming in on the WhatsApp, so we'll when it comes through, we will talk about that.
Yeah, keep your questions coming. We're live on Your Health, Your Choice this evening. It's Wednesday night. If you're looking on Thursday or Sunday evening, it will be a pre-recorded program.
Yes, yes.
So, okay, so we've looked at the causes, we looked at how common it is and the fact that one perpetuates the other. Remember, as we look at the slides, DM stands for diabetes and HTN stands for hypertension, and how they're linked. What about their risks?
Right, so when we talk about risks here, we know that some people, so let's just talk about, we know what the risk factors are for diabetes. If you have a family history, if you are carrying a lot of weight around the tummy, if you have polycystic ovaries, if there's your sedentary lifestyle, poor eating habits, all those things can lead to diabetes. Hypertension, there's some similar risk factors. Genetics is very important with hypertension. And also having too much salt in your food. We'll come back to that.
Yeah,
salt
sodium.
in your food, etc.
Yeah.
So, but what we're talking here about is the combination of hypertension and diabetes. What added risk does that lead to damage to other organs in the body?
Okay.
Because remember, the whole point of this is that hypertension, if it's controlled, you can live a normal life. Diabetes, if it's controlled, you can live a normal life. And I have this discussion with patients all the time because the thing is, patients will come in and say, well, my blood pressure is high, but I feel completely well. Why should I take medication? Well, the combination of diabetes and hypertension, we could, I think that's slide 8.
Yes.
Slide 8, we can show that, and there's some big words here. Diabetes and hypertension versus diabetes alone.
Yeah.
So if you have diabetes and hypertension, as opposed to diabetes alone, you are at a 1.6 greater risk of developing neuropathy.
If you define that quickly.
Right, so I'll come back and define it. You're at a 2-fold greater risk of developing nephropathy, 2-fold greater risk of developing retinopathy, 4-fold risk of stroke. Now, that's the one that really stands out, and a 3-fold greater risk of coronary heart disease, and overall a 2-fold increased risk of mortality.
Right. And mortality is death.
So mortality is death. Yes.
What is the question?
Right. We see questions down here.
Well, thank you for your WhatsApp questions.
Yes. Can drinking lemon water cause acid reflux? Just wondering. Okay, that's off topic, but I don't think lemon water can cause acid reflux. So I'll just leave that like that. I think if you're having acid reflux, you need to look at other reasons. What causes numbness in the foot? Okay, so again, not completely on topic, but numbness in the feet it's right. Yes, neuropathy. Thank you, Linda. Neuropathy is, we said that diabetes and hypertension can increase your risk of neuropathy by 1.6-fold. Well, if you look at that, that's almost a 50% increase. So what is neuropathy? It's nerve end damage.
Yes.
So nerve end damage to your feet, to your hands. You can have nerve end damage to your heart, to the stomach lining, which is autonomic neuropathy. You can have your heart rhythm being affected. Nephropathy is kidney disease.
Right.
So diabetes and hypertension can damage your kidneys. There's no doubt about that. Retinopathy, that's a big term for bleeding at the back of the eyes or damage to the eyes as a result of diabetes. But look at stroke.
Yeah, that's a kind.
Now, we say 4-fold, but that's a 400% increase in your likelihood of having a stroke if you have diabetes and uncontrolled hypertension. And I think, that's really of major concern, especially because people are not always aware that they have hypertension. And of course, we have coronary heart disease, and well, mortality is just death.
Yes.
From all these causes, as well as from...
so these are all this is how much likely you are to have these diseases as a result of the combination of those two.
Right. So what is happening is that there's a slow damage to the organs happening, and if you're not careful, if you don't control these factors, and the problem very often is, when the patients come in and we do their blood pressure and it's high in the office, and patients will tell you, well, my blood pressure is, it's normal at home. And that's a question we always have. Now, the dilemma is working out, and probably we could talk about this later on in the program, is this real hypertension? Diabetes in some ways is easier to diagnose than hypertension because, you can do a blood test, and if the HbA1c, which is a 3-month average, is raised, you know that patient has diabetes. Even if they come into the office and the blood sugar is well controlled, you still know that they have diabetes. But hypertension is one of the most notorious problems to diagnose, and that's why sometimes we have to resort to 24-hour ambulatory blood pressure measurements and, you know, ask patients to measure their blood pressures at home, etc.
Okay, so let's move on quickly to slide 9 before we get another question. The difficulties of having hypertension and diabetes.
The difficulty of controlling those two factors. So, yeah, it's come up already. So, slide 9. Systolic hypertension is the number above. So, I'll come back to that in a minute. Systolic hypertension is more common in diabetes. It's a stronger predictor of cerebrovascular events, that's strokes. 65% of type 2 diabetics may have systolic hypertension. Systolic hypertension is more difficult to control. Unfortunately, and this is just thrown in here, depression is more common in diabetes, and as a result, there's greater difficulty with people adhering to treatment. And then we have this whole term called clinician inertia. It's a big problem, and glycemic control is only the focus for a lot of patients with diabetes.
Okay, so there are a few things there that probably need a bit of clarifying. What is the difference between systolic and diastolic?
Right, so maybe I should jump in here and say the most obvious question people might ask me is what is a normal blood pressure?
Yeah.
So when you put the cuff, and you know, it's very deliberate how you should do a blood pressure reading. You shouldn't just do a marathon and go into the doctor's office and have your blood pressure measured. If you should be sitting for 10 to 15 minutes. Now, I mean, the strange thing about that is, you know, some people, if they're waiting for more than 15 minutes, which occasionally they may have to in some of our offices, they become a little bit agitated, etc. And that could, you know, if they have an appointment to go or something, that may send up their blood pressure. So we try to keep up to appointments, but it's not always possible. So sitting too long might actually send up your blood pressure. When you go into the doctor's office, or if you're doing it at home, your hand should really be relaxed. And on a table, I'm a little bit higher here, but the chair should be literally at the level of the table, and the hand should be at the level of the heart.
Right.
So you shouldn't do your blood pressure hanging down or your blood pressure with your hand up. It should be lying comfortably on a table, and the cuff that you're using should not be too slack or too tight.
Yeah.
Because that will give an abnormal blood pressure reading. And that's why you have different size cuffs. So you have cuffs for people who are very overweight. Some people have a lot of fat around the arm here. And you have to make sure that the cuff is not too tight. And sometimes doing the blood pressure on both arms is a useful thing, because you may find that there's a difference in blood pressure measurements in both arms. So measuring a blood pressure is not as easy as it seems. So I know we have to go to a break, I think.
Yes, we have our first break coming up.
Right.
Just quickly, what is clinician inertia?
Okay, clinical inertia, clinician's inertia is, as doctors and clinicians, we are not advancing therapy aggressively enough. So inertia means you get stuck. So not the patient just doesn't get stuck, but the doctors and healthcare professionals, we somehow say, okay, let's wait till the next visit. Let's wait till the next visit. Let's give lifestyle a chance when the blood pressure all this time is kind of bubbling. So let me just say before we go to the break, a good blood pressure is around 140/80, but...
Yeah, let's have the buts.
Well, when we come back,
we'll get to the buts. Yeah. Okay. Right. So thank you for joining us on our live program this evening, Wednesday, for Your Health, Your Choice. We're looking at the two terrorists in the medical world, diabetes and hypertension. We've looked at causes and risk factors and some of the difficulties of controlling them. When we come back, we'll be exploring some things, some other aspects of this combination, including the buts. Your Health, Your Choice returns in a few minutes.
Looking for a safe place for the whole family? Well, now you've found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values and family first. We are ACTN The Voice, your family-friendly station.
If you would like to relive the moments of the Gospel Music Awards 2019, have no fear. It can be viewed on ACTN The Voice, your family station, on Friday, March 8th at 8 p.m. It will also be streamed online on the ACTN The Voice Facebook page. Simply search ACTN The Voice. You don't want to miss this. Gospel Music Awards of Trinidad and Tobago 2019, only on ACTN The Voice, March 8th at 8 p.m. Every Sunday at 2 p.m. on ACTN The Voice, we will be taking you on a journey down memory lane with our Sunday classics. Relive the moments. Bonanza at 2 p.m. Little House on the Prairie at 3 p.m. Gilligan's Island at 4 p.m. Family Matters at 4:30 p.m. Hogan's Heroes at 5 p.m. The Jeffersons at 5:30 p.m. This is Sunday Classics on ACTN The Voice.
Welcome back to Your Health, Your Choice. This evening we're looking at the two terrorists of the medical field, diabetes, namely, and hypertension. Before the break, we were asking what was a normal blood pressure reading, and you told us, Dr. Khan told us, it was 130, 140 over 80.
I would say, yes.
And then you said there were some buts.
Buts, yes. So this is where individualized treatment for your patients come in, and what I call the art of doing medicine. So if you have a patient who, if I have maybe a 75 or an 80-year-old patient, I'd be happy about 140 over 80 because you don't want to drop that patient's blood pressure too low because they can have dizzy spells, etc. But if I have a middle-aged 40 to 50-year-old if they have bleeding at the back of the eyes, if they have microalbuminuria, that's a big term. It's a urine test we do, not a normal dipstick. It's one we send to the lab, and all diabetics once a year should have microalbuminuria testing. And if you have early kidney problems or even nerve end damage, then really we should be aiming for a blood pressure of about 130 over 80 or even 120 over 80, depending on how the patient tolerates it. Right, and that's where clinical experience comes in. With your patient sitting with you, you can dialogue with your patient and try to explain to them that the 140 over 80 may not be adequate. You may need lower blood pressure management.
Okay, yeah, we have a question, a WhatsApp question that came up during the break.
It was, and the WhatsApp number, well, is...
okay, so the WhatsApp number is 360-0105.
And we'll give the other number to call in a while?
Yes.
Okay, so this question is a question I'm often asked, Linda. What is a very good vitamin for diabetics, type 1 diabetic? Well, my opinion is that in Trinidad, we prescribe too many vitamins, multivitamin supplements. And there's this idea, it's a big industry, and I know I might get some flack for saying this, but really, and I'm looking at the evidence base now, there's no good evidence that people need a lot of multivitamin supplements. If you're eating healthily, if you're exercising, etc., you may not need all these vitamin supplements. So one of the things I would say is that if you want, sorry, we were sidetracked by some of the questions coming in. One of the things I would add, multivitamin supplements, is there's one called Diabetone, Diabione, Diabion, Diabetone. But really, if you're eating healthily, if you're exercising, etc., you probably don't need a lot of multivitamin supplements. The omega-3 fish oils, so let me just kind of
How they
break it down.
connect with...
Right. So omega-3 fish oils can give you a certain level of... The high-dose omega-3 fish oils can give you a certain degree of heart protection and also vitamin B12. So certainly vitamin B12 is a good supplement for most of our diabetics to take. Yes.
Okay, so remember we're a health education program, so any questions you have related to your health will be answered as clearly as he can by Dr. Claude Khan.
Right.
So, okay, we need to move on to the next slide.
Yes.
So as we get on to, we're looking at hypertension and diabetes in conjunction with each other. And there's something called the compound jeopardy. If we look at slide 10, this explains it a little more clearly.
Yes. So slide 10. So we have this whole concept of insulin resistance happening, and it begins with obesity. So on the left-hand slide, left-hand part of the slide, you have obesity, people who are very overweight. That leads to, the more fat you have around the tummy, the harder your pancreas is having to work. That leads to insulin resistance. And that then ties in, as a result of insulin resistance, to this whole concept of metabolic syndrome with hypertension, and then you have diabetes, increased risk of diabetes by 4, and then hypertension, obesity, diabetes, metabolic syndrome, all can lead to the ones in red. CAD is coronary artery disease.
Okay.
CKD is chronic kidney disease. PAD is peripheral arterial disease, and CVD is cerebrovascular disease.
So it affects almost all the organs in the body.
That whole combination.
Yeah.
So that's why we're saying it's a compound jeopardy. Yes.
I like that program, Jeopardy, actually.
Yes, I know you always like, and you answer most of the questions.
No, I don't.
Yes.
Okay, so let's move on to progression of cardiovascular risk.
Right.
And that would be slide 12.
Slide 12, okay. So I don't know if we're going to come up, there's a question I just wanted to address on the WhatsApp question.
Yeah. Okay.
It says, my mom has a stroke, her toes was cut off due to diabetes. Her foot twists and hurts, she can't sleep, too much pain. I'm listening on the TV. Okay, so again, it's not directly linked to hypertension, but I guess if she had a stroke and she has diabetes, she probably has some neuropathy, maybe also some peripheral vascular disease. So there are different types of medications that can be given. I mean, I've not examined your mother to know exactly what the problem is, but if it is peripheral neuropathy or painful neuropathy, there are drugs like Lyrica, gabapentin. There's a natural supplement I give called alpha-lipoic acid, and that can be given with painkillers.
These are all prescription drugs.
Lyrica, gabapentin, you can get it over the counter, but really they should be prescribed by a doctor. I mean, you know, people often ask me, you know, what are prescription drugs and what are over the counter? The problem in Trinidad is that almost everything you can get over the counter. We are quite lax in some of the prescribing. I don't know how that happens, but you can...
Is that clinician inertia too? Oh.
No. That's the pharmaceutical board.
Okay.
They should have oversight. As far as I know, really antibiotics and control drugs are monitored very carefully. But in America, for example, I don't think you can get glucophage even over the counter. You need a prescription. So these are prescription drugs. So your mom needs to be examined, and we need to establish whether it is diabetic neuropathy or peripheral vascular disease, etc.
Okay. So slide 12, please, Josh.
Right. So again, we kind of talked about this a little bit, but this kind of brings it home. The factors leading to increased cardiovascular risk. If you look at the left-hand side, it starts with impaired glucose tolerance. So even before you develop diabetes, then you have this coming in a anti-clockwise direction. ED is not erectile dysfunction, it's endothelial dysfunction.
Okay.
But of course, endothelial dysfunction can lead to erectile dysfunction. Prothrombotic, so we said that because of the endothelial dysfunction, you have this whole pro-thrombotic. In other words, the body is forming clots, the blood is becoming thicker. There's a pro-inflammatory response, the vessels become inflamed, visceral adiposity or visceral obesity, hypertension, dyslipidemia, and then you have
what's dyslipidemia?
Dyslipidemia, so we can just come off that slide.
Yeah.
Dyslipidemia is abnormal lipid profiles, abnormal cholesterol. So the dyslipidemic pattern in type 2 diabetes is often your cholesterol might not be too bad, but your triglycerides go up, and your HDL, which is your good cholesterol, it will be low, and therefore your LDL particles, which may not be very elevated, are very small and very dense, and they stick to the walls of the arteries. You know, as I was looking at that circle, the problem is sometimes patients only see one of those factors. They may come in with the high blood pressure or the high blood sugar, but they don't see what's happening inside of the body. And they don't realize that there's an inflammatory response. So, you know, patients may stick their finger and they may say, Doc, well, you know, my blood is running so nicely, I don't need to take aspirin. You know, you really can't judge. And I think the numbers come up now for calls.
Yes, so, right, so from this segment of the program, we'll be taking live calls in addition to your WhatsApp questions. So let's keep them coming.
Right.
You didn't finish the thought.
Yes. So, I'm begging patients to understand that. So what I've taken to do, Lynn, I have my smartphone. There's a cardiovascular risk calculator.
We have a call on the line. Yeah. Sorry, good evening. Yes, can we have your question, please?
Good night,
hello? Good evening.
Mrs. Doctor and Mrs. Khan.
Not hearing.
I am diabetic. I'm on medication for diabetes and low dose of high blood pressure and cholesterol. But about 2 weeks ago, I had a kind of a ringing on my chest on the left side, like if a blender is running. And I had that for a few seconds. It stopped, it came back for a few seconds.
Wow, it's a little bit difficult.
Should I be worried?
So, I'm getting some feedback on the... so you're having pains on the left side?
Yes, on the left side of the chest, and it sounded as if a blender is running.
Right. You're diabetic?
Yes.
And have you had any investigations done in terms of, is the pain coming on when you exert yourself or when you...
Actually, there is no pain. You're just hearing this sort of noise like a blender is running.
Right. Okay. I'm having so I'll just try to answer that question. I may have to ask Josh to turn up the volume a little bit on the speaker to be able to hear the calls. The thing with diabetes is even vague chest discomfort, etc. It may not be the crushing chest pain. You remember when we did chest pains? And in fact, there's a slide set from WebMD that we probably will do at some stage, talking about the type of chest pains that we should be concerned about. But diabetics don't often have the typical crushing chest pains. So that comes back to my smartphone. So what I do is I pull my phone out, I pull up the cardiovascular risk calculator, I enter the patient's age, the patient's blood pressure, systolic, diastolic, the patient's cholesterol levels, about 9 factors, whether they're a smoker, not a smoker. And then it gives me a cardiovascular risk. And if that patient has a cardiovascular risk of above 10% in the next 10 years, they need to be on aspirin.
Okay.
And
so that caller could have, maybe what we could do is ask callers to bring in their information, those 10 things that you require. To be prepared to talk about their age.
Well, normally as a doctor, I would, yes. I mean, I would have done their blood pressure. Obviously, they need to be truthful whether they're smokers or not. Their ethnicity, well, on this particular one, it's just 2, Afro-American or other. But normally, I would be able to accumulate that information during the patient.
I'm just saying when they call in, because we have another call on the line. Yes.
Okay. Yes.
Hello? Hello, can we have your question, please?
Hi, good night.
Good evening.
I love your program.
Thank you.
Yes, I recently had an A1C of 6.7. would you consider that as being diabetic or having prediabetes?
Good question. 6.7, I have to tell you, is in the diabetic range. Now, don't panic, okay? Because it's just above the 6.5 threshold. So those of you who don't know what the A1C is, it's the 3-month average. It's called a glycosylated hemoglobin. And it roughly tells me what your average blood sugar has been for the last 3 months. So all diabetics should have that, and we are now using it to screen for diabetics. So a 6.7 percentage A1C works out an average blood sugar of about 140 to 150. So that's just in the diabetic range. So, but what I would do is, if you're not sure, I would do a glucose tolerance test. So I would go to the lab, get your doctor to write up a GTT for you, and you do the fasting blood sugar, then you do the glucose drink, and 2 hours later you do another blood test. And that will definitely tell you. But it sounds like if you may have early diabetes, and really you should see a doctor for treatment.
But it is preventable.
Well, it could even be reversible. I'm not saying that it can be cured, but this is a stage where you want to intervene aggressively because we don't know if she might have hypertension. We don't know what her lipid profile is. So what will guide me in my treatment of this patient is what are the other risk factors we are talking about.
We have another caller on the line.
Yes.
Good evening. Can we have your question, please?
Yeah, good evening. I am diabetic and I'm on insulin 70/30. And I use 36 in the morning, 24 in the evening. But what I observe is I'm getting a lot of body pain. And I find sometimes I get chest pain. I don't know if the body pain could be coming from the diabetes or what could be causing the body pain then.
Okay, so he must have been diabetic for a number of years, and he's on 70/30 insulin, which is one of the commonest insulins in Trinidad. It's free on CDAP. And I don't think that will be causing your body pains, but a lot of diabetics do complain of body pains. Whether it's the diabetes itself, I'm not always convinced by that. Neuropathy, you can have a painful neuropathy. I think this patient needs to be examined properly. You may need to do some additional blood testing to make sure there's no inflammatory markers. He said body pains. I'm not sure if it involves the joints as well. But if it does, then you're looking more at an arthritic process rather than the diabetes. And the last thing is whether you're on a cholesterol tablet.
Okay.
So if he's on a cholesterol tablet, statins can cause myalgia, which is muscle aches. So may not be directly related to the diabetes, but something.
But it seems as though diabetes is connected to all the organs in the body. At some point, you're going to have pain. So we looked at cardiovascular risk.
Yes.
Progression of chronic kidney disease.
That's okay. So right. So we're looking here at slide 16, and slide 16 gives you the progression of diabetes, and the reason why we're showing this is it's why it's so important to monitor protein in the urine. So a lot of people are not doing this urine test called microalbuminuria, but if you have hypertension with diabetes, you're much more likely to proceed along this aggressively if it's not controlled. So you have type 2 diabetes with no microalbuminuria, type 2 diabetes with microalbuminuria, where the ACR is the albumin-creatinine ratio. If it's less than 30, that's okay. If it's between 30 to 300, that's early. If it's above 300, it's called macroalbuminuria. And then you have type 2 diabetes. It progresses down to decrease what is called GFR, is a glomerular filtration rate.
Okay, and you want to explain that.
ESRD is end-stage renal disease. I just wanted to answer a question here. Can you say what time you must have your last meal in order to do a fasting glucose test? You should have your last meal by about 10 p.m. Last meal by 10 p.m. You can have water to drink overnight, but your last meal at 10 p.m. I know we're a little bit kind of scattered tonight, but we're trying to answer the WhatsApp questions by phone and do the program, which is what we like to do.
Yes, yeah, it's all about information. We're on to our second break, and when we come back, we'll continue looking at some of the other aspects of the connection between diabetes and hypertension. Don't go away.
like to relive the moments of the Gospel Music Awards 2019, have no fear. It can be viewed on ACTN The Voice, your family station, on Friday, March 8th at 8 p.m. It will also be streamed online on the ACTN The Voice Facebook page. Simply search ACTN The Voice. You don't want to miss this. Gospel Music Awards of Trinidad and Tobago 2019. Only on ACTN The Voice. March 8th at 8 p.m.
You're watching ACTN The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station. ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. And before the break, we were answering some WhatsApp questions, so keep them coming. The number, 360-0105. You can also call in with your questions because we're taking you live this evening on Wednesday. If you're looking at us on a Thursday or a Sunday, it is a pre-recorded program. You won't be able to call in, but we do have a number that you can contact us on if you have any other questions later on in the week. That's 482-4269. And Dr. Khan will get back to you on WhatsApp with responses to your questions there as well. Okay, so we're looking at the twin terrorists of the medical world, diabetes and hypertension. And there's one question here we want to answer before we go into the rest of the program.
So, very good question. Does a doctor have to recommend aspirin? At what age could someone take aspirin? And you know, this question is much more complicated than people think. And the goalposts have been changing even from a purely scientific point of view. So there's no one age where I could say to someone, you should start taking aspirin at 40 years old or 50 years old. Calculations have changed. Yes, I think a doctor should be the one recommending aspirin. And the way I do it now, come back to my smartphone, I calculate the patient's cardiovascular risk, and it actually tells you after I do that, this patient should be on aspirin or this patient should not be on aspirin. I'm not saying all doctors should do that. That's just the way I do it, because sometimes a knee-jerk response, you know, a 50-year-old diabetic comes in, and we used to say all 50-year-old diabetics should be on aspirin. Well, actually, that's not true.
Okay. We have a caller on the line, so we'll take that question. Good evening. Can we have your question, please? Hello?
Hello, good night.
Good evening.
I have a question about acid reflux.
Acid reflux.
It acts up on me. My pressure goes up really high.
Sorry.
I don't know if the acid reflux causes the pressure to go up.
Well,
I'd like to know.
and I would have to say no, it's not directly related, but of course acid reflux can be very distressing. So if you have chronic acid reflux, you know, and you're not sleeping at nights, for example, indirectly your blood pressure may go up. But I would say a fair degree of certainty that there's not a direct correlation.
But then stress causes.
That's a good point, Linda. So stress can cause acid reflux, which definitely stress can send up your blood pressure. Like trying to get here on time tonight. That was very stressful, right? But we did make it. So, you know, my type A personality sometimes controls my rush
gets
to
my
get
blood pressure going.
Right.
So
Your blood pressure might be high
this
tonight.
interesting slide that we have next, slide 22. You used the word mortality.
Right.
And you mentioned that, you know, death is more prevalent among people with diabetes and hypertension combined. So let's have a look at this colorful slide.
Well, I mean, this is a very medical slide, but if you look at the horizontal axis, you'll see as the blood pressure is increasing, the vertical axis shows you CV mortality. Let's just look at it like that.
Okay,
and then
so CV, explain CV.
CV, cardiovascular mortality, cardiovascular death from heart disease, strokes, etc. And the yellow are the non-diabetics, and the red, that looks red?
Yeah.
Red is the diabetic. If you look at each blood pressure category, blood pressure is less than 120, blood pressure 120 to 39, blood pressure 140 to 59, 160 to 79, 180 to 199, greater than 200. Each of those categories, diabetics have a higher risk of cardiovascular mortality. And it escalates as the blood pressure goes up. That's why it's crucial, and it's crucial to control that blood pressure.
We have another caller on the line. Good evening. Can we have your question, please?
Yeah, good afternoon, and you have your choice?
We're hearing you, yes.
Yeah, what happened, for the past 4 years, I've had a high cholesterol level. And recently I was diagnosed, I checked my cholesterol, it was 240 something. And they put me on a rovastatin drug and with aspirin. But I haven't been diagnosed with diabetes. And I would like to know, my prognosis. But I believe I have to come down to your clinic.
Okay.
In Sogonas to do a comprehensive search. I'll bring down all my records. So I want to know what is the prognosis, because sometimes your cholesterol being 240 might be a concern as some of my research has shown now.
Right. So you're making a very good point that a high cholesterol in isolation, if you're not diabetic or hypertensive, may not actually need to be treated. I'm just saying. But more importantly, in addition, is what is your good and bad cholesterol? He just told us you told us your total cholesterol, but we need to know what your good and bad cholesterol, your HDL, your LDL, and your triglycerides. So yes, you need an overall assessment. There's someone asking here, if someone does an ECG test and it's normal, should he do a stress test? Well, I always say to patients, doing a resting ECG does not give you all the information you need about cardiovascular risk. Not everyone needs a stress test, but again, this is the art of doing medicine. If I see a patient and the patient has all these cardiovascular risk factors, then I would send them for a stress test. So if your ECG is normal, but you have a high cholesterol, you're a smoker, you have hypertension, you're above 40 to 45, I think you need to do a stress test.
Okay. Yes. I think we have another call on the line, and we have about 10 minutes left on the program, so get your questions in as quickly as you can. Yes, good evening. Can we have your question, please?
This is a first-time caller. I have a question, Dr. Khan.
Yes.
If you have diabetes, can you get pregnant?
Oh, yes, yes, of course. We have numerous diabetics who have become pregnant and have had very successful pregnancies. I think the question you might be concerned about is that you may have heard that diabetics have more complicated pregnancies. Now, that might be a reality. So what we often do is co-manage patients in pregnancy. The obstetrician is looking after the pregnancy itself, and the family doctor or specialist in diabetes will be looking after the blood sugar control. But very often hypertension can come into play with the diabetes. And the problem with controlling diabetes in pregnancy is that most of the drugs are not approved for pregnancy. The patients need to be on aspirin.
Okay. And then there's gestational
right, and then there's gestational diabetes. Yeah. I know time is going then, but can I just answer these two questions quickly?
Sure, yeah.
I'm diabetic about 2 years now. Is there any way I can bring down my A1C? Of course. Sorry, I don't know you personally, but it sounds a little bit hopeless there. Is that your A1C should not be elevated. We have a vast array of new therapies, insulin, lifestyle changes. That's why we have kind of renamed our center the Diabetes Wellness Center, because we are now networking with a fitness instructor. We are networking with a nutritionist, with a diabetes educator. And we'll give you some numbers where we have some outreach clinics apart from our Vistabella location. So it can be brought down. And yes, Linda?
Yes, there is hope.
There's hope.
There's another question. How can we prevent diabetes from age 30 up?
How can one prevent diabetes from age 30 up? Exercise, cardio, with resistance training. If you're overweight, losing weight. If you're eating unhealthily, and we haven't been able to talk about the DASH diet.
I really wanted to look at the DASH diet.
So maybe we should leave out some of the things.
Yeah, well, so the dietary approaches to stopping hypertension, that's what DASH represents in the DASH diet. And I think that, I'm not sure what slide that was, I think it was 39 or 36. But we have a little chart here that's quite useful as well for looking at the DASH diet. And I'm not sure if the camera can pick it up, but we've got your greens, okay, green leafy vegetables, and the portions of non-starchy vegetables taking up half of your 9-inch plate. And I brought in a plate here just to show you the size of a 9-inch plate that's required. And then a quarter of the plate will be your proteins, and then the other quarter, this is at the bottom half of the image, would be your the carbohydrates and the proteins. Okay, so really half of your plate should be non-starchy vegetables. We have examples here. You probably won't pick them up, so I'll call them out for you. Things like broccoli and Brussels sprouts, cabbage, cauliflower, cucumbers, dark leafy vegetables, eggplant, mushrooms, okra, peas, green peppers, salad greens, zucchini, tomatoes. All of that should comprise 1/2 of your plate. And only a quarter of your plate should comprise the carbohydrates, and then another quarter your proteins. Okay, examples of the carbohydrates would be things like, well, this is a vegetarian, and of course you're drinking water. So corn tortillas, fruit, berries, whole grain. So your whole grain pasta, whole grain breads, whole grain rice, with the pumpkins, beans, lentils, and peas, milk and yogurt. And then when we look at the protein foods, I guess milk and yogurt falls into that as well. Cheese, eggs, peanut butter, nuts, tofu, and so on. Now, these are recommended by the American Diabetes Association. So I think, you know, I keep this in my kitchen. This has actually come from my kitchen. So it's all bent and greasy. And this isn't the actual size of a plate, a 9-inch plate, nothing more than 9 inches. So that's part of the DASH diet.
That's excellent. Thanks, Linda. Someone is asking about our office locations, which I'll come to in a minute. But can I show slide 39? I think this might be one of the last slides.
5 minutes.
We only have 5 minutes left. Slide 39. So these are the hypertensive lifestyle modifications, because I didn't want to just talk about medications, because there's lots of tablets to talk about, but regular 30 minutes of moderately intensive exercise, at least 3 to 4 times a week, no tobacco, no smoking, definitely, minimizing alcohol, and there are guidelines for that. Sodium restriction, less than 6 grams of sodium per day. Avoiding high salt foods like pickles and savories. Use of potassium containing fruits.
Okay, so just quickly to outline some of the potassium rich foods would be bananas, mangoes, melons, apricots, dried fruit, prunes, and raisins. Okay, that will give you the potassium that you need.
That you need. But can I just say that one of the things about potassium is that if you have renal impairment, you then have to cut down on potassium-rich foods. I don't want people to get too confused. We're saying for hypertensive controlled, some of those potassium-rich foods are good, but you want to cut back on the salt, the high salt foods.
And I've noticed a lot of these beverages that we have are high sodium beverages as well, even though, you know, they're sugary drinks,
yes,
but they also have high quantities of sodium.
Right.
So you need to read the labels on your drinks.
And there was another slide that we don't have time to show, that if you do these lifestyle changes, you can actually reduce your blood pressure and blood sugars significantly without, before we even put you on medication. But I want to hasten to add that because hypertension is so complicated in diabetes, very few people with hypertension and diabetes can be controlled just on lifestyle. The lifestyle goes together with the blood pressure medication. And I think we only have...
We have 2 minutes left.
2 minutes. So there's a vast array of blood pressure tablets, not only the CDAP tablets. So you need to, you know, see someone who can control this. Someone was asking us, and we don't often advertise our locations, but the Diabetes Wellness Centers, we're located in Vistabella, and the number there is 482-4269, and in Shogunas on Caroni Savannah Road, and the number there is 665-1141. And we are now beginning to have an outreach soon in the Pinal area. Just before you get to Pinal, at Dr. Biku's office, I'll soon be there. And the number there is 324-0720. And we may have an outreach into the Port of Spain area, in the St. Clair area. And the number there is 235-3604. Now, I know that's all confusing, but we are looking at ways of having some extended arms from the main center so we can spread the word about diabetes wellness. I think we have about 1 more minute.
Yeah, so you better put your pastor's cap on quickly.
So, wow, we've had to cover a lot. You know, when we are live, it may not be as compact because we're taking questions and WhatsApp messages, etc. Linda, on Sunday at church, I shared a bit about how do we accept each other. And that's a big challenge because very often people are judged according to appearance, according to their societal standing,
status,
academic background, etc. And I challenge the church, if someone came into our doors wearing a tongue ring or an earring or dressed in a way that we may not traditionally associate with church, how do we receive those people? So I know we have to end, but the two things is we should accept people as they are, and acceptance does not necessarily mean approval. So can I say this? Parents, everyone who's listening, we may not approve of our children's friends, etc., but we need to accept all and receive people as they are, but not necessarily approve of what they may be doing.
I think, you know, we as Christians are being judged as well by the world. So it is a reciprocal thing. Thank you for joining us on Your Health, Your Choice. We'll be back in a fortnight's time. Don't forget, we're on air. Well, not on air, but the program will be played again tomorrow, Thursday, at 1 p.m. and then on Sunday evening at 8:30.
No, 6:30.
Sorry, it's now 6:30. We've changed the time to 6:30. Your Health, Your Choice returns in a fortnight's time with a different topic. Good evening.